Hi everyone, I am Emad Magdy, lecturer of nephrology, Mansoura University. Uh, our topic today will discuss the relationship between drugs and kidney. The best description of this relationship between the drugs and kidney is that it is a bidirectional bond or bidirectional relation. Why? Because the kidney is affected by the drugs by many mechanisms, and all the structures of the kidney can be affected by the drugs and its metabolites. And on the other side, the pharmacokinetics of drugs and pharmacodynamics of drugs is affected also by the kidney function, and that is what we will discuss in this lecture. We'll hit these 5 points. Number one, what are the spectrum of the drug affection on the kidney? Yani how can any drug affect the kidney? This is number one. Number two, what is the magnitude of the problem of medication errors in chronic kidney disease? And is it related to the patient prognosis or the patient safety or the patient morbidity and the mortality or not? Item number three is the effect of chronic kidney disease on the drug pharmacokinetics. The how to make those adjustments according to renal function, and finally a simple algorithm for drug prescription in patients with chronic kidney disease. Let's start with number one, or the target number one of the main targets of the lecture. What are the spectrum of injuries that drugs can make to the kidney or can induce to the kidney? If we see here, we can see this image. Forget for the drugs now, but if you can see here, we will discover that the drugs can affect all the kidney structures, and they can affect the kidney by all the physiological mechanisms of kidney injury. So you will not find any kidney disease etiology which is no place for drug in it. If you revise your studying in any topic, you will see in the etiology something is called drug induced. And this is why it's very important in taking history from any patient with renal disease to ask about drug. And this is very important even in the OSCE exam, because the history station is a very important station in the OSCE exam in the kidney. Sure, you will have marks on the do you ask about the drug history or not, because there is no renal disease cannot be induced by drug, and there is no mechanism of renal injury cannot be induced by drug. So if we try to divide the mechanisms of injury, we can differentiate it into mechanisms of drug. Yani drugs affect the glomerulus, or drugs affecting the tubulointerstitium, or drugs causing obstruction for the kidney. So all the mechanisms is available. Let's see an example. The mechanism of glomerular injury, it can be direct cellular injury. So the drug itself is nephrotoxic and cause drug cellular injury, or this drug can induce an immunological process like the autoimmune disease. Or another more important and more frequent and more common is the drug affect the perfusion of the kidney, so through the functional or hemodynamic effect. So this is how I summarize the glomerular disorders coming from the drugs. If you try to find an example in the direct cellular injury, you know here, you know the terminology of the glomerulus. The glomerulus here is this is the Bowman's capsule with one lining of cells, then the Bowman's space. This is the capillary, glomerular capillary. This glomerular capillary, the blood come from inside, and anything outside the glomerular capillary is urine. those glomerular capillaries are superimposed by the podocytes, and inside there is an endothelial cells inside the lining of the glomerular basement membrane and in between the glomerular basement membrane. All the capillaries are merged in a mesangium. Mesangium means the matrix that hold all the capillaries within the glomerulus. And this mesangium contain collagenous fibers like this and contain mesangial cells. And in each glomerulus, we have vascular pool and tubular pool. This is the proximal convoluted tubule that collect the urine from the Bowman's space. And this is the afferent and efferent arteriole, and between them the macula densa and the renal angiotensin system controlling side. This is simply as a glomerulus. Each part of the glomerulus can be affected by the drug. If we take the podocytes can be directly injured by the drugs, and we know that the podocyte injury will make us the two famous known histopathological changes, which is called minimally changed disease and the focal segmental glomerulosclerosis. So the minimally changed disease and focal segmental glomerulosclerosis are also called podocytopathies. So the main problem in the minimally changed disease and the focal segmental glomerulosclerosis is the podocyte damage. So the resultant effect will be, if we damage the podocyte, the resultant effect will be proteinuria. This is the main clinical presentation, will be the main clinical presentation of the patient. And this effect can simply be induced by the non-steroidal anti-inflammatory drugs. And I'd like you to just concentrate on the non-steroidal anti-inflammatory drugs, because when I end or finish all the mechanisms, you will find the non-steroidal in each of them. So the non-steroidal can cause podocyte injury or can cause podocytopathy, and the podocytopathy will be presented with minimal change disease or focal segmental glomerulosclerosis. Another cell which can be affected is the endothelial cell. Endothelial cell is the lining of the glomerular capillary from the inside, from the side of the blood. If this endothelial cell is injured or damaged, it will have a rough surface, and on this rough surface, the platelet will aggregate and form a thrombus inside the glomerulus in a pathology named thrombotic microangiopathy. And a great group, I'll not go to depths. I'm just telling you the meaning of the word, because just studying these words without knowing the meaning, it will be very, very difficult. But this is why they are named like this. If endothelial injury done, the surface will be rough, and the RBCs will be fragmented at this rough surface, and the platelets will aggregate, forming a thrombus. So it will cause thrombotic microangiopathy. One of the most important drugs that can cause this is the calcineurin inhibitors. The calcineurin inhibitors is a very widely used immunosuppressive drug. It is as a cyclosporin and tacrolimus. It is used in various immunological disease and in various cancers. The mesangial cell affection is not common, so I will not go inside this. So maybe the problem is an injury to the mesangial cell, and this will cause atrophy and fibrosis of this area of the mesangium, so we'll need to glomerulosclerosis. But because it's not that common, I will not go deep. This is the direct cellular injury. We have on the other side the immune-mediated injury. What is the meaning of immune-mediated injury? It means that the drug induces immune response, whatever the mechanism. It can be an antigen which come into kidney structure and an autoantibody reacts to it, one mechanism. Or maybe it is an antigen antibody complex formed anywhere but precipitated in the kidney, because the kidney is the filter of the blood, so it can be. Another third mechanism can be just an antibody which affect the small blood vessels, and the glomerular capillaries is of these small blood vessels. So it will cause a small vessel vasculitis. Okay, so the immune-mediated injury can be immune complex disease, lupus-like, or membranous. What's the meaning of membranous? These immune complexes will be deposited in the glomerular basement membrane, making it not functioning well, so will lose protein and blood in urine. And this also can be induced by the non-steroidal anti-inflammatory drugs, by the hydralazine, and by the penicillamine. The small vessel vasculitis, if you consider that all these capillaries are prone to necrosis or inflammatory cell infiltrate, sure, the patient will come with renal failure. Why? Because these are the spaces of the filtration of the kidney. So any damage here or any loss of this space due to inflammatory cell infiltrate or due to inflammation or due to rupture of the membrane will affect the kidney perfusion and will cause acute kidney injury. And this is again can be induced by various antibiotics, by infliximab. It is an monoclonal antibody used for the treatment of autoimmune diseases, and by the propylcyanuracil. Again and again, the examples of drugs is too many than this, but it's not my aim to exhaust you with names. I just give you the very commonly used examples, but it's not the only drugs. But my aim is not to make the lecture silly and full of unused knowledge. I'm just telling you the very important example. So this is the direct cellular injury and the immune-mediated injury. Come to the second, the most common or very important or very important mechanism that we will encounter in each specialty, because as you see here, some drugs of these are very specialized to prescribe except for non-steroidal, sure, but here the spectrum of drugs is more wide in use and can be used by many physicians. This is the effect on the afferent and the efferent arteriole. We have drugs that constrict the afferent arteriole, so it will decrease the intraglomerular pressure, and sure, it will decrease the GFR. Those, the very important of those are the non-steroidal anti-inflammatory drugs and the CNI and the combination analgesics. This combination analgesics is now outdated. There is no one can use this, but in the last century, in the mid or late of the last century, the combination analgesic was commonly used. Phenacetin plus aspirin plus COX inhibitors. This was a very destructive combination to the kidney perfusion and will cause glomerular ischemia. So, but now still we have non-steroidal and CNIs. ACE and ARBs will not act on the afferent arteriole. It will act on the efferent arteriole, causing vasodilatation. So again, the vasodilatation of efferent arteriole will decrease the resistance inside the efferent arteriole, and this also will cause drop in the intraglomerular pressure. But this effect can be beneficial to the kidney if the problem of the kidney is the increased intraglomerular pressure, like the diabetic nephropathy or hypertensive nephropathy, because in the hypertensive nephropathy and the diabetic nephropathy, the pressure in the glomerulus is very high, so the ACE/ARBs is preferred. But if the patient is having low intraglomerular pressure due to afferent vasoconstriction or due to dehydration, so the ACE and the ARBs here will be harmful and will cause GFR decline. Till now, you are satisfied or get confused by any idea of what I say?
No, it's good, doctor.
Okay. This is a very simple presentation of what we said, the difference between non-steroidal and ACE and ARBs, because we should know now that the combination is very harmful, because if I use non-steroidal in the patient will cause afferent arteriole vasoconstriction, and at the same time efferent arteriole vasodilatation by the ACE or ARBs, so sure I'll expect the GFR to be low. And this also will tell you, this is a separate topic, not the aim of my lecture, but this is why we tell you in the last case that the ACE inhibitors is very dangerous in the bilateral renal artery stenosis, and we cannot use in the renal artery stenosis. Why? Because in the renal artery stenosis there is intraglomerular hypotension by the pathology. So if we add on efferent arterial vasodilatation, so the GFR will drop and drop. And this is why in the case, the patient, when taking ACE inhibitor, the renal problem aggravated and the patient presented with AKI. Why? Because the patient is already have a diminished glomerular perfusion or glomerular. The idea, I think it's clear now. So number one was the mechanisms of drug-induced glomerular disease. By the way, you can study any disease in the nephrology by this way. The structures of the kidney are glomerulus, tubular interstitium, vascular, and lower urinary tract or post-renal. Those are the, you can put all the disease under this scheme. Another very important effect of the drugs on the kidney, this one. Let's concentrate in this section of the histopathology. Usually in normal kidney, those are the kidney tubules. In normal kidney, the kidney tubules is coalesced to each other. It's not separated like that by the interstitium, or it's very narrow spaces between the tubules, and this wide space indicating acute tubular injury. This is tubulitis, inflammatory cells in the tubular wall, inflammatory cell infiltrate in the interstitium. All these blue nuclei in the interstitium. These are eosinophils. These are neutrophils in the peritubular capillaries. This is the picture of acute interstitial nephritis. So some drugs can induce by idiosyncratic action. It is not dose and the time dependent action. It is not related to high dose or small dose. It is not related to the duration of use of the drug. No, it is an hypersensitivity action, as it will be in the skin or in the larynx or in the respiratory tract. On the kidney tissue, it can have this hypersensitivity reaction with tubular damage, tubular inflammatory cell infiltrate, and again, what's the problem? If I lose a tubule, or if I lose, what are the main functions of the tubules? The main functions of the tubules is they diluting and concentrating about the kidney. This number one. Number two is the electrolyte absorption and secretion. So and if the tubules is getting necrosed or getting obstructed, there will be no urine. So all the spectrum of kidney come in the tubular interstitial injury. Do we have certain drugs that can cause? This is this real picture of autopsy of a patient with. This is the gross picture of kidney with acute inflammation from drug or hypersensitivity action from drug. As you see, the effect is seen grossly. It's not It's not just microscopic. And to your knowledge, sure, we have common drugs that cause this, but any drug can cause interstitial nephritis. So I should expect again the drug in the history of any patient presented with acute kidney injury, because the acute interstitial nephritis can be present in any drug. It is just an hypersensitivity, so hypersensitivity to any drug can be, but those are the common. If you see the common, you will get afraid from prescribing any drug, and this is the message in this lecture. Prescribing drugs is not that easy mission. This is number one. Number two, prescribing a drug should be justified, should be in the high indication and the high benefit of the patient, because if you encounter this problem with your patient and you are from the start prescribing a drug on no basis, you will be blamed. But if you prescribe the drug for the benefit of the patient under a guideline or under a justification, you can defend yourself that I am justified to prescribe this drug, but it is hypersensitivity and I cannot guarantee hypersensitivity from any drug. But the situation, if the drug is not indicated from the start, will be very painful. Okay? If you see here, the antibiotics, the penicillins, the cephalosporins, the nonsteroidal is of the commonest. This is the maybe the most common mechanism of action of nonsteroidal on the kidney. It is more than the glomerular affection of the kidney. So if you like to know that, nonsteroidal affect the kidney most commonly by, number one, the hemodynamic effect, because it's causing afferent vasoconstriction, and number two is by the interstitial injury, and it can induce interstitial injury by the acute mechanism, and in the next slide by the chronic mechanism. Those are the three common mechanisms of injury. As you see, nonsteroidal can cause injury by any mechanism, but the hemodynamic is number one, the interstitial is number two, that the interstitial can be acute or chronic. It's clear now? Okay. Diuretics or antihypertensives can be a cause of interstitial nephritis. We have in the last 5 years many reports blaming the proton pump inhibitors, omeprazole, for causing acute interstitial nephritis. And you will see in the practice that the doctors or the patients use this medication as an OTC for the hyperacidity. So no drug without possible side effects. I am enforced to be justified to prescribe the drug for the patient. So in the intertubular interstitial injury, we have the acute, and again, this acute is hypersensitivity, is not related at all to the dose or the duration. This is the contrast. This is the chronic interstitial nephritis. Here, the tubules and the glomeruli start to be sclerotic, and the inflammatory cells start to be chronic inflammatory cells, and this will cause gradual deterioration of kidney function until to be end-stage renal disease. But this mechanism is cumulative. So the larger the dose, the greater the duration will be the incidence of. So I cannot expect a chronic interstitial nephritis when some patient presented to me having just 1 week usage of nonsteroidal antiinflammatory. It is not logic. It can be an acute, but the chronic use of nonsteroidal for more than 10 to 15 years in high doses can cause this. And this is also a very important drug because it's used the antipsychotic drug for the bipolar disorder. You know the bipolar disorder? Bipolar disorder is schizophrenia, mania depression. Lithium. So nonsteroidal and lithium are the commonest drugs that can cause this again. all the examples here is not all the examples. It's just the important example. I am intended to put these pictures, especially the gross picture. Here you can see what can the non-steroidal cause to the kidney in the chronic use. This is a kidney. You see this, the structure number 16 is the renal papilla. One of the effects of the chronic non-steroidal use is, which is called, it's an old term now, it's called analgesic nephropathy. Analgesic nephropathy is combined of chronic interstitial nephritis and papillary necrosis. This the cause of the renal papilla. This is the gross picture of this change. Do you see the effect? Do you see the harm? It is not a simple task. It can lead to chronic renal failure and end-stage disease. The final mechanism of injury is injury due to crystallization of substance. Yeah, what's meaning by crystallization? That a drug help crystallization of some materials or ions in the tubules, causing obstruction of the tubules, and this obstruction of tubules will cause renal shutdown. So there are chemical agents and the medication that could kidney damage by forming crystalline deposit. طبعا الفوليوم depletion and the conditions favoring nucleation and lack of urinary inhibitors of stone formation are contributing factors. What are the common examples for this? The hypercalcemia. It is you are noticing that all the population are abusing using the vitamin D supplementation and the calcium supplementation. All the ladies should take calcium and vitamin D, and all the old age and all the lactating pregnant. Sure, some cases are indicated by the hypercalcemia due to excess vitamin D, cause calcium phosphate to be deposited in the kidney and cause crystal nephropathy. In these days, consuming large quantities of vitamin C allow calcium oxalate crystals to form. This is a real practice. You will find this in the practice. You will find some patients that have a very bad attitude in taking vitamins with high doses for a long time. This will affect the crystallization in the urine and affect the pH of the urine and induce stone formation. Another problem, which is a forgotten one, is the hyperuricemia. We have some drugs that cause hyperuricemia, like the thiazide, frutamide, cyclosporin, and this cisplatin used for the malignancies. It's a chemotherapy. All these chemotherapeutic agents can cause hyperuricemia, or the chemotherapeutic agent by its cellular attacking mechanism can rupture the malignant cells, liberating the uric acid inside in a syndrome called the tumor lysis syndrome, causing uric acid nephropathy. So in some chemotherapeutic agents, when I treating the malignant cells with chemotherapeutic agent, this agent will rupture the cells, liberating the inside uric acid, a storm of uric acid in the kidney, crystallization, and obstructive kidney disease. So these are the mechanisms, and these are the main. This will was the main core of the lecture. Come to the simple part of the lecture: medication errors in chronic kidney disease. You will see here that if we try to sum the problem in the chronic kidney disease, what affect the patient quality of life and morbidity and mortality, you will find the drugs. So in the chronic kidney disease, there is a problem of anemia, multiple transfusion, multiple diagnostics, edema, hypoglycemia, cognitive impairment. You will find the drug in the toxic medications, the problem in drug dosing, because the drug dosing of the chronic kidney disease should be changed, and we will discuss it in the next point. The multiple medications, because the patient is having multiple problems in the chronic kidney disease and usually come accompanied by diabetes, hypertension, cardiovascular disease. So the multiple medications, drug dosing, toxic medications, all this affect the problem. And on this insight, the effect of chronic kidney disease is the effect of drugs on the chronic kidney disease. Now it is the effect of chronic kidney disease on the drug pharmacokinetics. This is a very important effect to know, that patients with renal impairment often have alteration in their pharmacokinetic parameters, such as drug absorption, distribution, protein binding, biotransformation, and renal excretion. So this kidney is not working well, and the kidney is a major organ for excretion for the drugs and the drug metabolites. So the drug pharmacokinetics will be changed. Elimination of many drugs is dependent on renal filtration and secretion and reabsorption. Therefore, the clearance of drugs eliminated primarily by this mechanism is decreased. So if I know from the this drug is mainly renal excreted, when I have a problem in the kidney filtration or GFR, so I should expect that I should lower this drug therapy dose, and I will get the same benefit. If I use a drug with the same dose of the normal kidney, so the patient may encounter toxicity of the drug. Patients with severe renal insufficiency can experience accumulation of the metabolites, which can contribute to toxicity. Patients also have an altered pharmacodynamic response to a given drug because of the physiologic and the biochemical changes associated with progressive renal insufficiency. So it is not only the pharmacokinetics, it's not only the absorption and the excretion. The way of the body responding to the drug is also changing, because the chronic kidney disease is a multi-system disease, and it affects the homeostasis, and it affects the environment for action of all enzymes and all hormones. So it is not that simple to prescribe a drug for chronic kidney disease patients. And those are 4 very important examples. Number 1, the drugs with narrow therapeutic index. Do you know this term? Do you know the drug with narrow therapeutic index, or not? Don't know this term?
No.
Drug with narrow therapeutic index means that a drug that the difference between the therapeutic dose and toxic dose is very narrow. So the plasma level in such concentration is beneficial, but it can be harmful in a slight difference in the concentration or slight higher in the concentration. Those are named drugs with narrow therapeutic index. And those drugs this is why those drugs are very importantly to be monitored in the patient with chronic kidney disease, because as I mentioned in the last slide, that the chronic kidney disease impairs the excretion of the drugs, especially if there are renally excreted. So the aminoglycosides, the digoxin and the warfarin, you can be encountered very easily by drug toxicity in the chronic kidney disease patient. So those drugs, the aminoglycoside is nephrotoxic, and the digoxin, warfarin are very tightly used in the patient with chronic kidney disease. Another very important and very common agent is contrast. IV contrast. The contrast, especially the iodinated and the hyperosmolar contrasts used in the diagnostic implications of the CTs or MRIs or diagnostic angiography in the cardiological disease. The contrast is nephrotoxic, and they can crystallize, and they can cause tubular defect, interstitial defect, inflammation. So you will find before any contrast injection, the physician will ask for determination of the kidney function, because it cannot be possible without a good kidney function. So digoxin, warfarin, contrast agents are very important drugs. This is based on how the chronic kidney disease affects the pharmacokinetics of the drug. Dose adjustment according to renal function is very simple, and this is what we should know. Yani, this is a lesson to the practice. We should know the GFR of the patient with chronic kidney disease before prescribing any drug, and it's very easy. The GFR can be measured by 24-hour urinary collection, which is hard, but can be done very simply by the estimated GFR equations, which is available on the softwares of the smartphones. This is one example. We have many calculators for on the smartphones. This is one example called QX Calculate. This QX Calculate have all the equations of the medicine listed by specialty, so you can use it very easily. It is the dashboard of the program or the software. It's a mobile app, very available or very easy. Those are all the equations used for calculation of the GFR. You can select anyone like this. This is eGFR by CKD-AB equation. Just it will ask you 4 questions: gender, race, age, creatinine, so and will give you the expected clearance or the estimated clearance. This is another common equation, the MDRD. Again, the same informations, very simple informations. You will know the GFR, and then while you are prescribing the drug, just if you take the index of the drug, you will see here like this. If the patient have renal impairment and you'd like to give him 750 milligram per day, if the clearance between 20 to 50, give him the usual dose. If it's 10 to 20 or hemodialysis or peritoneal dialysis, you will give him initially 550, then 500. If your primary aim is 500, you according to the clearance, all the drugs again in a very simple free mobile apps. This is the Medscape app on the smartphone. So really, we are blamed if we do something harmful to our patients related to the dosing of the drugs according to the clearance, because the utility is very easy and very reachable. Just to know it is not that big deal. And this is a final slide. What are the drug prescription algorithm I can use in patient with CKD? I can at first have a detailed initial assessment about previous drugs, allergies, current medications, the volume status of the patient, laboratory data for renal function, liver function, and albumin concentration. Why albumin is important? Because albumin is reflective about the intravascular volume, because the patients with hypoalbuminemia will lose their intravascular volume to the interstitium. So the patient may appear from outside that there is no volume depletion, but really he or she has a volume depletion because all the fluids escaped from the intravascular compartment to the interstitium. Then evaluate the degree of renal impairment, as I discussed, through the measuring by 24-hour urinary collection or estimation, and then review the medication list, the doses of the drugs, the maintenance, the initial. So we have initial dose and the maintenance dose. We have dose adjustment according to clearance, patient on hemodialysis or not, patient state, patient comorbidities. All these can be adjusted. And then after applying the drug, I should monitor, especially the drugs with low therapeutic index, monitor for drug response and toxicity, monitor for hypersensitivity, and then revise regimen. And this is what we do in multiple drugs. Just I will take you final example. When I prescribe ACE or ARBs for a patient with kidney disease, if you see the SRA and ARBs, you will find it had a beneficial effect in reducing the proteinuria and reducing the intraglomerular pressure and reducing the fibrosis. So it's beneficial. But I am afraid from the vascular effects that I mentioned at the start of the lecture, this efferent arterial vasodilatation. So I will monitor. I have a guideline for this. I will prescribe the ACE in moderate dose at first, and then repeat assessment of the GFR after 2 weeks, and repeat assessment of potassium after 2 weeks. And I will compare it to the basal level. If the basal creatinine is increased more than 30% of the basal level, I will stop the drug. So the drug is not, I cannot take the benefit from the drug now. If the drug causes hyperkalemia, especially the chronic kidney disease patient is liable to hyperkalemia because of the diminished kidney function, I will stop the drug. So the monitoring and the revising the regimen can let me benefit my patient from the benefits of the drug and avoid the hazards of the drug. At this point, I am finished. This is my channel on the YouTube, and this was a suggestion of your previous colleagues in the previous year in the conventional and the Manchester program to have some videos that describe the difficult topics in nephrology, some questions, some revision sessions. You will find here, if you have any, sure, this is not an official channel. It's يعني my own channel that يعني an attempt to help you, not just more than this. يعني if you have any topic, we have topics for history taking, examination, all the difficult topics in the curriculum are discussed here in a lecture or in a question session or revision session. Thank you. Yeah, and don't hesitate to ask me any question if you have. I am finished. Any question? Any question يا شباب؟ طب فهمتوا حاجة؟ فهمنا حاجة؟
Yes, doctor.
تقيلة ولا ايه رأيكم؟ I believe that all the time يعني is lost in just discriminating the ideas. If you put this lecture in handout, it will be not more than 2 pages. Okay, I leave now. Do you have any question?
No, thank you, doctor.
No, thank you.
Okay, thank you. Goodbye.